Welcome to the presentation on the fundamentals of nursing. I am Dr. Catherine Prado-Lefkowitz with Nursemuse, and I'd love to welcome you to this NCLEX review series. So on Nursemuse, it helps you write care plans, and it has a ton of resources on there. And I'm also going to package up nursing school for you on Nursemuse so we can hit all of the highlights so everybody listening can pass their NCLEX and be successful. So the first video is fundamentals of nursing. So let's jump right in. So the objectives here, we're going to talk about the nursing process and the ethical principles that drive nursing care. We're going to talk about legal documentation, some theoretical models of nursing, and then I'm going to stop this video, and then the part 2 will pick up with pain. So let's do the first 4 objectives. So the nursing process. So we all know that the nursing process has 5 steps. The first is assessment. This is the most important, probably the most important while you're taking in-class examinations as well as NCLEX examinations. We always need to assess first to find out what's going on with our patient. So this is the most important step, step number 1. We're going to collect the data. We're going to take vital signs. We're listening to the heart and lung sounds, and we're trying to figure out the underlying problem so that we can relay this to the healthcare team. We need to notice any changes that are occurring, and if you follow the same pattern every time you do an assessment, head to toe, then you'll never forget a system or forget where you are. So assessment, number 1, you always need to assess to find out what's going on. The second part, we take that assessment and we come up with a nursing diagnosis. Nursing diagnoses, these are how patients respond to what is going on with the patient. So maybe somebody with heart failure, we don't want to say that the person is in heart failure because we don't treat the heart failure. We treat what the patient is responding to that heart failure. So we're going to work on decreased cardiac output. So how do we work on decreased cardiac output? Well, we need to have a plan. So the third step is planning. So we set a plan of action of how we're going to help increase cardiac output with the patient. Okay, so we're going to come up with goals. The goals are what the patient will do. So the patient will ambulate. The patient will complete their intensive spirometer exercises. Whatever the patient is going to do, this is the plan. The interventions are what the nurse is going to do. So what is the nurse going to do for the patient? Maybe the nurse is going to give the medications to the patient. Maybe the nurse is going to educate the patient. So interventions are what the nurse does. Then we're going to implement. We're going to take charge and do the plan. So we're going to implement our interventions, trying to reach that plan. And then the evaluation. Were the goals achieved? Was the plan achieved? How do we know? This is why we need SMART goals. So make sure you know what SMART goals are so that they're specific and measurable and attainable and they're time sensitive. So you can't just say patient is going to ambulate. Patient is going to ambulate 10 steps 3 times within the next 12 hours. Make it very specific and measurable because then either the patient met the goal or the patient did not meet the goal. If the patient did not meet the goal, then we have to start this whole process over again. So nursing process, remember this when you're taking questions on NCLEX. Now, the nursing profession, we abide by code of ethics. So what you need to know is that each state has a board of nursing. You need to be familiar with your state's board of nursing because each board of nursing has their own Nurse Practice Act. This tells you what you can and cannot do as a nurse in that state. You also need to know what other people can and cannot do in terms of CNAs, LPNs, RNs, nurse practitioners, because if you delegate a task and it's not in somebody's scope of practice, then you are not following your own scope of practice. So you need to know scope of practice, huge term you're going to hear all through nursing school, and the Nurse Practice Act is where you go to find all this information. We also use evidence-based practice in nursing. We don't do things because it's always been that way. We use the best data we have from peer-reviewed literature. This guides our practice. Okay, we like peer-reviewed literature because this has been studied and tested, and it shows us that this is the best, safest method to do whatever you're doing. the American Nurses Association. So this group is established and they create the ethical standards of care for our profession. Okay, so they set the ethical standards. I don't know if you know this, but there's usually an ethical team in hospitals and facilities. So if you ever come up with an ethical question or an ethical dilemma that you can't seem to work through with the family or the patient or your nurse manager or your director, you can always take ethical questions to the ethical team and they will meet and they will make a recommendation. They never tell you what to do, but they will make a recommendation of what the literature says is the best way to move forward. So always remember that. And remember the A and A. So we have ethical principles that we need to follow every time we're caring for a patient. So you need to know these terms and what they mean. So autonomy means that the patient has the right to decide what treatment they will and will not accept. Okay, so the patient can say yes or no to treatment. That is their right. We must uphold the right of the patient. Okay, when we talk about beneficence, this is to promote good. So our whole goal is to promote good for our patients, always doing the right thing, making sure that we're going toward the good standard. Then we have non-malfeasance. So this means we do not harm. We avoid causing harm. This might mean checking a medication label over and over, making sure it's the correct patient at the correct time, the correct dose, the correct route. So we're going to do no harm. Justice. We're going to treat every patient fairly. We do not treat patients based on their ability to pay, their insurance, their race, their sex, their gender orientation, how much money they have, etc. We treat every patient fairly. Fidelity is to keep our promises and to stay loyal. So when you say you're going to come back in 10 minutes, you need to come back in 10 minutes. You need to uphold your promises so that patients can trust you and trust that you mean what you say. Advocacy, we need to do what the patient wants us to do. Again, this kind of goes with autonomy, but we need to advocate for our patients. If they say they don't understand something or they're not comfortable with the treatment, we need to speak up and let the provider know, let our nurse manager know, let somebody know so we can advocate for our patients. And then veracity is to tell the truth. We do not lie to patients. We do not give false reassurance. And this is important in your NCLEX and school exam questions. We never give false reassurance. If the patient asks if a procedure is going to hurt, it might hurt. We don't want to say no. We don't want to say everything's going to be fine. We don't want to say everything's great and dandy because it might not be. So we need to tell the truth, of course, in an empathetic way. But really understand those ethical principles because the NCLEX and your in-class exams like to integrate those ethical principles into case studies for the question. So advanced directives. So these are important to know as a nurse. So advanced directives fall under the Patient Self-Determination Act. So the patient has the right to make decisions about their own health care. Advanced directives, it means that the patient's allowed to direct their care in advance. And this is a legally expressed wish. So the patient can have a living will. It's a document drawn up which indicates the interventions that they do and do not want to have, such as if they're in a horrible accident and they cannot speak for themselves, this legal document tells you, I do not want to be intubated, I do not want tube feedings, and it's already set and done, and that's what we're going to do for the patient. A do not resuscitate in the event of cardiac death. The patient says, I do or I do not want CPR. Now, just remember with a DNR, we do need physician orders for this. So if the patient has a DNR, make sure we get an order in the chart for a DNR. A durable power of attorney. This is a legal document that designates another person to make medical decisions for the patients. This person does not need to be related to the patient. If the patient has a durable power of attorney and it lists their spouse or mother or father or a friend, then we need to call that person designated on that form and ask how we proceed with the care of that patient. HIPAA. I'm sure you've all heard about HIPAA. So HIPAA is a law that sets forth protecting patient medical records. You are allowed to discuss care of the patient with other members of the healthcare team who is providing direct care to that patient. So we can share information with friends and family if the patient has signed a release of information for those persons. If they have not, then we need to get that release of information signed, or the patient might decide that he or she doesn't want to sign it, and that's fine. Then we cannot discuss treatment with those people. We do not speak about patients in public areas, such as elevators, the cafeteria, in the hallway. So just really protect your patient's information. You only speak about it to the people taking care of that patient, to the people who need to know, and anyone not in the medical profession who is just a friend or a family, make sure there's a release of information. Now, when using an electronic health record, this is very important. You always need to use a strong and unique password to log into the patient's charts. We never share our passwords ever, and we always log off every time we walk away from the computer. You do not want somebody coming behind you and logging into a patient's chart and documenting on that patient under your name. And you only want to access charts for patients that you are caring for. This is very important. It doesn't matter if your neighbor got into an accident and he or she is on 2 floors above you and you want to see the prognosis or what's going on. This would be a HIPAA violation if you logged into that chart. You are only allowed to look at the chart for the patients that you are caring for that shift, that day. So let's talk about some torts. So we have unintentional and intentional torts. So an unintentional tort is an unintentional act that caused harm. So there are 2 categories that fall under this. The first is negligence, and the second is malpractice. So negligence is a failure to provide care that a reasonable nurse would have provided. Malpractice is negligence by a professional, such as an RN, so you can be charged with malpractice, where you had a duty to act but failed to act in the correct capacity. So let's say you unfortunately overdosed a patient or gave the patient the wrong medication and the patient had a negative outcome. Even if the patient didn't have a negative outcome, you could still be charged with malpractice because you did not act in the correct capacity. You did not verify the medication, the patient, the route, the dosage, all of your 6 rights that you're supposed to look for before giving a medication. So of course, this is an unintentional tort. You didn't mean to harm the patient. You didn't mean to do the wrong thing, but you did. So this falls under malpractice. Next, we have intentional torts. So this is a willful act that violates patient rights. So an assault is a threat. So if we tell a patient, if you don't stop acting up, I will tie you down. This is an assault. Versus battery, which is actually touching the patient without consent, and that touching of the patient causes harm. So we give a medication, IM, that the patient refused. We can be charged with battery. So assault and battery, we make a threat before we touch. So think of it that way. So A before B, assault before battery. We make a threat, and then we take action. False imprisonment, this is huge. So we need to understand the policies and procedures of our facilities. We need to understand what the doctor's orders for each patient. So for example, the 4 bed rails being up could be considered false imprisonment. Now, if the patient has a doctor's order for this, he or she has been assessed and it's made apparent that the patient needs this for their safety, this will be time limited. You'll have an order for it. But we don't like to have all 4 bed rails up because the patient, especially if they're older and maybe frail, not easily able to get out of bed. So false imprisonment is keeping someone against their will. Another example is putting a patient in seclusion without an order. Or if a patient is trying to leave AMA and you block the door. Or if we put someone in a wheelchair and we tie them down to the wheelchair. This is all false imprisonment. Defamation of character. So this is making derogatory remarks that harm a reputation or has the potential to harm the reputation. So under this, we have slander and libel. Slander, S, think speaking, spoken. S is any defamation of character that is spoken, gossiping. Slander, S, speaking. And then we have libel, which is writing it down. So you make a Facebook post or you hang up signs, defaming somebody's character. Abandonment. This is a huge one. So in order to be charged with abandonment, you need to desert a patient when you should be taking care of the patient. So let's say you come into your shift and you take the 8 patients you're assigned to for that day and at noon you decide to leave and go home, but you don't tell anybody, you don't turn the care of those patients to somebody else, you can be charged with abandonment. So make sure you understand what abandonment is in your Nurse Practice Act. You cannot be charged with abandonment if you do not take care of the patients. If you come in and you don't want to take the assignment of 20 patients you were given, you can say, I refuse the assignment, but you haven't taken the responsibility of those patients. If you do take responsibility, you do get a report, and then you say, I can't do this, and you leave, then you've abandoned your patient. Just know that nurses, we are healthcare professionals, and we are mandatory reporters. So we have to report any suspicion of abuse for a child, a vulnerable adult, or an elder person over the age of 65. So we do not need facts. Of course, we want to document everything that we see to help back up our suspicion, but all we need is a suspicion. So we don't need proof. We just need to document why we suspect negligence or abuse. Of course, we need to document what we're seeing, what we're hearing, what the patient's telling us, what the loved ones who are with the patient are telling us. Document, document, document. Always get your nurse manager, your charge nurse involved to maybe go in and do another assessment, just so you can have as many people documenting the suspicion as possible. So your primary action is to protect the patient from harm. So our goal is to remove the patient from the suspected abuser. So if this is a female 25, you believe she's in a domestic violence situation, you might ask her, to come with you to give a urine sample. Anything to try and get the patient away from the abuser without making it so obvious. Now, if that 25-year-old does not want to press charges, denies that anything is happening, but you have suspicion, you cannot call the police just because you feel that this person is in danger. She is not a vulnerable adult. All you can do is give her information, help her to develop a safety plan, provide information about shelters and refuge, and try to educate her as best you can. But if there's a child or a vulnerable adult or an elder over the age of 65, you do need to call the authorities, that you are a mandatory reporter. So let's talk about some theoretical foundations that you need to know as a nursing student. We have all these names. I'm sure you've heard about them. So we have Kohlberg, Erickson, Maslow, and Piaget. So these are the four that I would say that you really need to know as a nursing student and as a nurse. So just remember that the theories in nursing focus on the relationship among the person, environment, health, and nursing. Person, environment, health, and nursing. And all of these people have contributed to those in one way or another. So let's talk about Kohlberg. So Kohlberg, his whole theory revolves around thinking, reasoning, and making choices in life. So Kohlberg has stages that are sorted into three levels. We have the pre-conventional morality, the conventional morality, and the post-conventional morality. Each stage involves a more advanced level of reasoning that coincides with the cognitive development and life experiences. So level 1, pre-conventional morality. This is the most basic level of moral development. Moral reasoning is based on externally controlled rules that are handed down from authority figures. So these are little children and they listen to their parents, their teachers, their caregivers. Level 2, conventional morality. This begins to emerge around the age of 10 or 11. They're accepting of rules in various social groups. And then stage 3 or level 3, this is establishing good interpersonal relationships. So moral decisions are based on how they affect these interpersonal relationships. So think about teenagers, right? They're all into interpersonal relationships and getting along with everyone and starting to learn some adult coping skills, coping mechanisms, seeing how social groups interact. So the pre-conventional is less than 5 years old. You get a reward or you get a consequence, right? You listen to your parents, your caregivers. Conventional phase is 6 to 12, how the actions affect people. And then post-conventional, like I said, 10 to 13 and on, You're developing your abstract thinking and you're thinking about the world in a more complex. Now, Maslow's hierarchy of needs, this is very important because a lot of NCLEX questions, you always need to think about Maslow's hierarchy of needs. There are 4 needs here. You can see the very bottom is physiological. So there are many needs for a human being. We have the physiological to the self-actualization. We cannot move from physiological to safety unless our physiological needs are met. Okay, so we can't move from physiological to self-actualization in one day. We can't be worried about love and belonging without having food and shelter. Okay, so know these stages, know these levels, because a lot of NCLEX questions ask you, without stating it overtly, you need to think about the Maslow's hierarchy of needs. So do they have food? Do they have shelter? Do they feel safe where they are? Can they pay their bills? Can they get to where they need to get? Then we can worry about, do they have friendships? Do they have loved ones? And then we can worry about, do they have a job where they feel accomplished? And do they have high self-esteem? And then we can worry about, do they help other people? Do they have a feeling of fulfillment? We can't expect people to go out and, donate their time and be helping the community if they don't have a safe place to live with a roof over their head and not worrying about where their next meal. Erickson, I'm sure you've heard about him. So he talks about stages in human development. So each stage has a psychosocial crisis. So the first stage, infant, is trust versus mistrust. When I cry, does somebody come? Okay, that's basically trust versus mistrust. If I cry, does somebody come? If not, I'm not going to trust my caregivers because they don't fulfill my needs. School age, industry versus inferiority. So they're learning through crafts. They're um, away from their peers and away from their learning environment in the hospital. So you need to make sure as a nurse that they are getting their homework, maybe that they have a couple friends that they can call, maybe their friends want to come in and visit. So am I doing stuff and is it making a difference? And then 40 to 65 adults. This is when you're kind of looking back on your life. Your children have left the house, you're retiring, you're living a new life. Is your patient saying, I love seeing my children leaving, I love being a grandparent, or is the person in crisis, trying to hold on to his or her youth? Now, there are more stages for Erickson. I just want to pick out the major stages so that you as a nurse understand. Infants, trust versus mistrust, the school age, especially if they come in for surgeries, they need to be learning, they need to have their homework, they need to have peers call them, they need to, have some feeling like they're actually working toward goals, and then end of life, really happy with their life. So here's an example. You can go through all of the stages to just make sure you understand what each stage kind of talks about. Again, in a lot of the NCLEX questions or the exam questions, you're going to get asked to identify which stages the patient should be in, and if the patient is in that. Piaget, Perceptions and Cognitions, he talks about how children learn about the world. And kids, as we know, see and experience the world in different ways. So think about the babies, ages 0 to 2. Children explore the world through sensory motor, right? They touch everything, they crawl, they put things in their mouth. They're experiencing object permanence, meaning if I move an object out of sight, is the child able to still understand that the object exists? Then we move from like 2 to 7, the pre-operational magical thinking. This is fun to take kids to Disneyland because magic is real. We treat inanimate things as though they're alive. So we play with our stuffed animals, we play with our Barbies, we make them talk and, have fun with each other. And we are in the pre-operational magical thinking. Then we get a little bit older, 7 to 11, concrete operational. So this is like when it's a term called conservatism. So when an object is transferred between containers, it does not change the amount in those containers. So they're starting to see that things can take different shapes in different objects, but yet they're the same. And then from 11 on, we start developing our abstract thinking that persists into adulthood. So we can look, read through the lines, pick up on social cues, know what it means to be, to have a social appropriate behavior in social settings. So here, again, I just gave you a little table so you can review